Gigi, can you talk about the NCI study?
That it's ongoing, or did they release something?
Yeah, where to find results? I went on their site. There's a PR announcement, but there's no data.
I think that's because they don't have any data yet.
Okay.
There was a Doug Lowy talk from NCI yesterday on a NIH serology call, and was kind of showing what their plans were.
Okay. Any timeline?
Actually, I didn't catch that. I don't know if it was mentioned.
Yeah, I don't think they have a timeline for when they're going to share the results. I think they've only looked at about 10 kits so far.
Oh, right. The same ones at the UCSF study?
I don't know. They haven't said.
On the slide, is this still in practice mode, or are we? Looks like it says live on YouTube. I don't want to talk out of turn, but they did show a list, and there was some different ones.
Oh, great.
We're going to start broadcasting in just a few seconds, so I'm going to go ahead and mute everyone. All right, good morning. Welcome to the webinar on COVID-19, Update Serology and Return to Work. My name is Elizabeth DeWolf from the American College of Occupational and Environmental Medicine. Before we get started today, we're going to cover some of the Zoom features that we'll be using. There are two different features available to communicate with the panelists and other attendees. You may post general messages in the chat feature. Messages can be shared with either the panelists or all participants. Use the drop-down box to select who you want to share your message with. You can go ahead and give that a try right now by introducing yourselves. Let us know who you, where you're from and what your role is. If you want to share that with all panelists and attendees, so we can see where you're from, that would be fantastic. And then the next item, the next feature that you can use to communicate is the Q&A box. And all questions should be going into the Q&A box. Panelists are monitoring this box for questions and not the chat feature. So please be sure to post all questions in the chat box. I'm sorry, in the Q&A box. And in case you're not familiar with ACOM, we are a membership organization that provides leadership to promote optimal health and safety of workers, workplaces, and environments through education, research, development of public policy, and advancing the field of occupational health. All right, before we get started, let's cover some technical details. We are recording today's session and we'll email the link to the recording to all registrants. And in case you don't receive the email, the link to the recording will also be available at acom.org. We are offering 1.5 hours of CME for today's webinar. A link to complete the evaluation and claim the CME will be emailed to all attendees with the recording information. And now, today's webinar is being moderated by Dr. David Rumpel from the Division of Occupational and Environmental Medicine, University of California, San Francisco. Dr. Rumpel, glad to have you with us today. And we're looking forward to another fantastic presentation. Would you like to tell us a little bit more about today's webinar?
Yeah, I'm happy to. Do I need to share my screen now? I do. Hang on a second. While I work through this. we go. You should be seeing my full screen with the introduction now. Welcome everyone to, I believe this is the 6th or 7th ACOM COVID-19 webinar on treatments and on presentations. And this is the second one we've done on serology on return to work. We did one 2 weeks ago, but already there's new information published in the literature that we wanted to share with you. We're lucky today to have 3 speakers with us who are experts in the field to talk about recent research on serology and return to work. The first speaker is Jeffrey Whitman from UC San Francisco, from the Department of Laboratory Medicine, and we're talking about a large-scale study that was done with colleagues from around the country on test performance evaluation of, I think, 12 different serologic assays, one of the first large evaluations like this in the literature. The second speaker is Gigi Grunwald from the Center for Health Security in the Department of Environmental Health Engineering at Johns Hopkins Bloomberg School of Public Health. And she'll talk about their publication on the national strategy for serologic testing and the application of that strategy to return to work. And then we moved on to the Q&A part of this webinar, and that'll be led off by Ellie Thiel from the Mayo Clinic. She's the director of the Infectious Disease Serology Laboratory and associate professor from the Division of Clinical Microbiology. The only financial declaration is that Dr. Thiel is a consultant to Roche Diagnostics. Let me see if I can go to my next slide. So 2 weeks ago, we talked about serology and immunity, conclusions from prior coronavirus epidemics from the SARS 2003 and the MERS 2012 epidemics. And we learned from those epidemics that IgG titer peaks 3 weeks after symptom onset. We seem to be finding similar results with COVID-19. 85% with disease developed IgG, and both IgG and neutralizing antibody, and we'll talk more about what a neutralizing antibody is, last for 6 to 36 months. In those epidemics, there were no cases of reinfection. The neutralizing antibody is a measure used to identify immunity, although there are questions about the level and whether it really does provide immunity or not, and it's different from IgG serology. So we'll talk about the difference between those two. In terms of immunity to SARS-CoV-2, what we know so far is that these are small studies. The Wolfel study from Germany, only a sample size of 9, that 100% of people with mild disease developed neutralizing antibody 2 weeks after symptoms, so evidence of immunity. And then from China, the Wu study of 175 patients, 95% developed with mild disease developed neutralizing antibody. And then we have a number of animal studies. I think the 2 most relevant are, or the one most relevant is the 2 rhesus monkey study. And that study found that those rhesus primates did not develop reinfection when re-exposed to CoV-2 virus. That's, I think, what we know. We may hear more from our presenters about these issues. In terms of the application of return to work, we know that there are workplaces where the prevalence is high. It's not 0.5% or 1% as in the general population, but the prevalence is 15 to perhaps even up to 65% in meatpacking houses, nursing homes, prisons, homeless shelters, ships, among healthcare providers, paramedics, first responders. So we're really now looking at the predictive value for serology tests in settings where the prevalence is high, and therefore predictive value should be better. And some of the return to work decisions are, workers have a persistent positive PCR test. And you can see in the curve on the right here from Zhao that the positivity rate persists for quite a while. We expect that active virus or virus that's cultured might last for up to 9 days after symptom onset. But the PCR can remain positive even much longer, up to 4 weeks after symptom onset. So would serology be useful in those kind of settings in terms of identifying workers that could go back to work and they have a false positive PCR test? What about protecting vulnerable populations like nursing home residents? Would it be valuable to test from a serologic standpoint workers who work in those settings so that we only send workers in who are have IgG or neutralizing antibodies? And then the other one is, what about protecting vulnerable coworkers? If you're working on an assembly line, like a meat packing line, and you're not separated at more than 4 to 5 to 6 feet from your adjacent coworker, should we think about alternating workers on the line so you have one person who's serologic positive, the next one negative, the next one positive, and so on down the line to provide some kind of protection? The same consideration might come up for example, oil platform workers who are flown out to oil platforms in the Gulf of Mexico and have to work in close proximity with other workers for 2 weeks. Is there any value for testing workers who fly out before they go out to identify those who are serologic positive or negative? So there's a lot of return to work kind of questions. And there are big issues about whether serology really provides immunity or not. And that's part of the discussion today. So with that introduction, I'm going to stop my screen sharing and turn it over to our first speaker, and that'll be Jeffrey Whitman. You can take it away, Jeff, and he'll talk about their study on serology assays.
Great. Thank you so much for that introduction. I'm very pleased to speak today. Just to let you know a little bit more about myself, I'm a clinical research fellow in the Department of Laboratory Medicine here at University of California, San Francisco. And the study we really wanted to do is see how these tests, these serological assays for SARS-CoV-2 performed sort of head to head in a larger specimen set. Though we will go over the intricacies of all those testings and our specimen set as well. I'd also like to point out, I don't know if you can all see my mouse, but hopefully it's here, that these are not all my affiliations down here. I just wanted to point them out that this was a large collaborative effort between a lot of institutions here in the Bay Area, and this is representative of a lot of research input from a lot of great groups. I just want to say I have no conflicts of interest to declare, and also emphasize that this is a preliminary report. This is preliminary data that we are presenting, and it has not gone under peer review. And the aims and takeaways that I really want people to get from this talk are that I want to discuss what common serology testing modalities there are for SARS-CoV-2. So for those who may be ordering tests or have to interpret tests, just knowing how those tests works becomes very important, and knowing what your laboratory or your clinical laboratory may be doing, I feel, is very important. And I'd also like to provide insight into study design that goes into generating these test performance characteristics. And in this way, when you read a lot of literature that may be coming out on these studies, you'll understand some of the strengths and weaknesses and limitations that go into it. And I also I don't want to start out with too cheesy of a Venn diagram, but I think this is really important, and it sort of summarizes kind of what I want to bring to the table, is that really the answers and insights for using SARS-CoV-2 serology are going to come from a lot of different areas. They're going to come from the molecular biology of disease, and also of just knowing how these tests work. They're going to be coming from the epidemiology of the disease and what it means in the population. And also understanding the healthcare systems and public health systems that interface with all these tests. So the answers and insights are in the middle. And I'm not going to say that we bring everything to the table, but that's why it's so important to have these discussions from multiple standpoints. So overall, what is the utility of test performance evaluations? And I think I've outlined a couple points here. I'm sure people could add in other things, but I think it's really important to understand how these tests perform in terms of clinical sensitivity, specificity, how they work in different populations, to understand their appropriate use and how to interpret their results. So when you get a result back, and it's just one test, knowing what the strengths and weaknesses of those are very important for how you use that clinically and practice medicine. Secondly, understanding how these tests perform in different populations is very important as well. So we always talk about our patient populations. They are different in different regions depending on where you're practicing. So understanding how these tests maybe work in heterogeneous populations or specific populations that you're working in. So these would require different and multiples and large scale studies. It's important to understand these for crafting clinical and public health policies. This could include how you do clinical algorithms or multi-step testing algorithms. And it's also a great feedback to developers who may not have access to a lot of samples and really provide a really genuine feedback in different patient specimens that may not always be available. And I want to point out that we are not the first to evaluate SARS-CoV-2 serology tests. There has been 2 preprints out before us from a group in Copenhagen and also one from the UK. So I'll also just put those out there. So jumping right in, here is a sort of outline, a very broad overview of how these serology tests work. First of all, you collect a patient specimen. It could be serum, plasma, or whole blood. And the antibodies that are contained in that specimen from that individual go into the test. The test itself, if it's an indirect immunoassay, like we are looking at for these SARS-CoV-2 serologies, there will be a reagent that is an antigen from what you're detecting. So for in this case, it is a viral antigen from SARS-CoV-2. And if the individual has preformed antibodies to these antigens, they should bind in the test kit. From there, a secondary antibody that binds to a certain class of human antibodies like IgG or IgM can attach if there is preformed antibodies there. And it has an enzyme linked to it that will turn over a colorimetric substrate, and that color can be measured. So that's really what we're measuring is the output here. So it's sort of a quantification of the antibodies that are present in that specimen. However, sometimes the results are used qualitatively versus quantitatively. I will try not to get too much into the weeds, and I'll also say that there's a lot of different modalities and different methodologies for doing this, but this is the general principle. So what does this mean when it's applied to in an actual test format? So here are 2 common serology testing modalities. One is an enzyme-linked immunosorbent assay, or ELISA. The other one is a immunochromatographic lateral flow assay, or LFA. And one thing that I'm not covering here is actually the sort of high throughput immunoassay and serology platforms like that are put out by the pretty much run in major clinical labs like the ones from Abbott, Roche, Siemens, et cetera. We'll not be covering those. These are more of the ones that are in the ELISA and LFA format. So jumping right into the ELISA, that color that's produced that we just talked about is actually read by a spectrophotometer. And the amount of color is quantified, and a cutoff is set by the manufacturer or the laboratory itself to determine if it's positive or negative. So here we see an example of an ELISA. This is actually not a SARS-CoV-2 one, but you can see this is a mixture of positive and negative specimens, and there is some variation in color, and that's what's measured and determined if it's positive or not based off its cutoff. For the LFA assays, what's actually read is the colored band on the test strip here. So those viral antigens or those antigens that you're detecting are printed on the strip. A specimen is placed here and chased with buffer, so it diffuses up the strip. If those antibodies are present, they can bind to the test region, and there's also a control region to make sure that your assay is working appropriately. Now, what's different about these, even though they're sort of capturing the same information, is that they're actually interpreted by an individual or a reader, as they're usually sort of a point of care style test. So they're not always regulated to be run as a point of care test. And so the individual decides if there is a band, and many of the package inserts that you read will say any band constitutes a positive. So these are generally read qualitatively as a positive or negative. And it's also important to note that there's a specific time frame for reading these established by the manufacturer. A lot of times there'll be a 5-minute window after a certain incubation period. And our study evaluates 2 ELISAs and 10 LFAs. Another thing I want to point out about our lateral flow assay method that's maybe not in the convention of using these clinically is that we used a band intensity score. So we said even if there was a faint band, that it would be called positive, but we also wanted the reader to assign sort of a score to it. And this had been previously used in studies by ours. So we have a score from 1 to 6, where 1 being the faintest band and 0 being completely negative. But I really want to emphasize that this was for research, and that the package inserts really note that this is a qualitative assessment by the readers. And that you can, this score itself is really used to capture data about the band intensity related to our specimen set and assays. And as I mentioned, the test performance evaluation, for this test performance evaluation, any band greater than or equal to 1 was considered positive. So what about the specimens and specimen set that we used? We had availability of serum or plasma, remnant serum or plasma from 129 SARS-CoV-2 RT-PCR positive specimens that came from 79 symptomatic individuals. And if serial samples were available, only 1 per patient was included for each 5 days from date of onset of symptoms. And that was because we wanted to see how these sort of kinetics of serology may affect test performance. So we binned people into 0 to 5 days, 6 to 10, 11 to 15, 16 to 20, and greater than 21 days. So within each one of these time bins, there was no more representation than 1 patient for those analyses, but overall we did collect some serial samples on patients. We also wanted to analyze 108 pre-COVID 2019 blood donors. So these were all collected, blood donors collected before July 2018. And lastly, we had 52 specimens that were RT-PCR negative for SARS-CoV-2 and or had a respiratory pathogen multiplex PCR panel. In our case, it was BioFire, which is a very common panel, respiratory panel that you can look up that includes viruses, bacteria, fungi. Then the other thing I'd like to note about our study population is that we tried to include as many people as possible. So we did capture some clinical data on their highest level of care, being either ambulatory, admitted, or ICU. But I want to note that as time went out, you'll notice that the ambulatory patient population actually went down. And what was really most represented was the ambulatory patient in the early time points, which sort of makes sense for the presentation. It was really the admitted and ICU patients we have in the later bins. And that may be important as emerging evidence comes out about serology, sort of kinetics and dynamics. So here's a graphical example of our study design and what we did for actually testing these specimens. First, we took all of our specimens and we randomized them to a 96-well plate. And it was actually multiple 96-well plates. And this was important because the LFA is a subjective read, and so you want to blind the readers to what test is being run. They shouldn't know if it's positive, negative, or otherwise. Subplates were made from this master plate for each assay to minimize freeze-thaw cycles, so you could just take out 1 plate and use it. And the tests were then run by an awesome group of laboratory volunteers, some of which were blinded readers. We had 2 individual readers assess the test separately and record their scores, and those were passed to a data analysis team, which did a great job on very innovative ways to look at these test performance characteristics. And I will note we kept the readers separate from data analysis because we didn't want any test performance data that was coming out to influence their reads. So it was very, very aggravating for them maybe to have to wait until the end to see the test results. So here's our first result that I'd like to talk about, which is the detection of these SARS-CoV-2 antibodies by time from symptom onset. Now, one really important thing I'd like to put out here, I realize there's a lot of information on this slide, so we'll just walk through it, is that the y-axis right here is % positivity compared to RT-PCR. So this is not comparing serology to serology. This is how this compares to the RT-PCR, the presence of nucleic acids of these viruses in these individuals. So this was done from their nasopharyngeal or oropharyngeal swabs. And this, where the actual serology itself is from serum or plasma. And as I said before, we looked at how positivity was affected, % positivity or detection of these antibodies was looked at by time bin. And really what we see is what really matches with the literature, that over time, all these tests, so each of these dots and whiskers here is a test plus the 95% confidence interval of their percent positivity. And we see that over time, the detection of these antibodies increases, and it increases at the kinetics of the serology studies that are currently being published. So which is a good finding. So we see that our percent positivity of serology is actually in the greater than 16 to 20 day region. So either 16 to 20 days or greater than 21 days. The 95% confidence intervals are kind of wide here, so we can't make a lot of assumptions. But these are really the time bends where you will have the maximal positivity, at least what we see in our study. We also broke down the percent positivity by individual antibody classes. So in this top one, we're looking at percent positivity as IgG or IgM. If either was positive, it was counted as a positive. But we also break it down by individually IgG and IgM. And what we see here is that IgM was really less consistent across tests than IgG. IgG was a lot more had a lot more equal test performance. And definitely the 95% confidence intervals for all these things overlap for a number of cases. So that should be taken into account as well. Next, we also wanted to look at specificity of these tests. And so to look at specificity, which is really the percent without disease that are ruled out by the test, which is a calculation of what you would classify as true negatives divided by the true negatives plus false positives, we had to go to pre-COVID-19 specimens, where there was a fair amount of them that we were able to evaluate from the blood donor specimens previous to July 2018. Now, one thing I'd like to point out here, again, I will walk through this visualization, which I think is a great visualization, but it needs a little bit of discussion. So each column here is a test. And each colored each row here is actually a specimen. And each colored band, if it's blue, related to the LFA score. So this is the subjective score that was made by those LFA readers. And the purple ones here are actually the ELISA signal to cutoff ratio, which is a function of that colorimetric reading that we talked about. So the big thing to point out about the testing in these pre-COVID-19 specimens is that when you calculate specificity, saying either IgM or IgG was positive, the specificity ranged from 84.3 to 100%. So there was sort of heterogeneous specificity in the test that we observed. And this was, and we saw that the majority of false positives were more observed in the IgM component, and a lot of them were low intensity. And the big thing to point out here is this is just the subjective band read that was read by those blinded readers. And we can't really differentiate here between if this was an antibody cross-reactivity, if it was non-specific binding, or if it was an assay-specific factor. It's just the fact that an independent reader interpreted it as positive, as was described in the package insert. The ELISAs would be a little bit different in that they would have a detection over the cutoff level that was used. The last figure I'm going to show is that same sort of heat map where each column is a different test and each row is a specimen. And the heat map scoring is the same. We see here with the ELISA in purple having the signal to cutoff and the LFA being the individual reader score. And the important thing to talk through here is that this is a fairly limited cross-reactivity panel, if we want to call it that, because we didn't capture a lot of patients who had acute viral infections, but we did pick up some. We have some of the seasonal coronaviruses, patients who were affected by seasonal coronaviruses, some specimens from individuals who had flu, parainfluenza virus, adenovirus, respiratory syncytial virus, or a human rhinoenterovirus. We also had a number of individuals down here who didn't test positive for any viral testing. And again, as I mentioned, the respiratory pathogen panel multiplex PCR was our BioFire panel. And this black strip right here shows you who had that testing. And then on this black strip, we see those who had the RT-PCR testing and were negative for SARS-2. And the big takeaway from this, just the sort of overall picture from this visualization, is that we didn't observe any pattern or trend in cross-reactivity with other viral respiratory illnesses. But we really want to make sure that this was that we were limited in our specimen availability to have a variety of viral infections. So definitely more studies are needed in this area. And the last thing I'd like to point out is we did notice some specimens were, a few were positive across multiple kits. I think the big one to look is down here at the bottom where no other viruses were detected. And we saw that it was positive in quite a number of specimens or by quite a number of kits. And this could suggest that there is an example of an infection that was detected by serology, but not by RT-PCR. How this fits into a whole testing modality, this is still to be worked out, but this is more of an example that we observed in our data. Now, with any study, there are strengths and weaknesses, so we'd like to talk about our limitations. I think one limitation we have is that there's relatively low power for the positive specimen set, especially when broken down from time from symptom onset. We're looking at bins of individuals who were RT-PCR at, in the tens of specimens to 30s of specimens. But that's just kind of what's available and curated out there, at least in our population in our specimen set. We also didn't evaluate matrix effects. So matrix effects relate to what type of specimen that you're testing. So these serology kits could use serum, plasma, and some of them whole blood as well. And there just wasn't enough to break down. There wasn't enough specimens to break down between serum and plasma separately. And we also didn't do any evaluation of whole blood or finger stick or capillary blood. So a lot of these point of care style tests, people may want to use them with finger stick blood. So that is another characteristic that should be evaluated and would be done so, should be done so if it's to be validated to clinical standards. Lastly, we didn't collect any specimens or weren't able to collect any specimens on asymptomatic or convalescent cases. And this is important because emerging evidence may suggest differences in antibody levels in these populations. I will say that keep your eye on the literature. This is a very emerging topic, but it is a limitation because a lot of people may be using or expecting to use these tests in these situations. And we really don't know how how cases that are true infections in these either asymptomatic populations or convalescent cases really perform. So our conclusions I just kind of boiled it down to a couple of things, is that we saw that percent seropositivity increased over time, peaking in samples that were collected in 16 to 20 plus days. And this really matches the current emerging serology kinetics that we see from studies that have recently been released. We see the detection of antibodies by RT-PCR was more heterogeneous in detecting IgM, but overall there was a lot of overlap in 95% confidence intervals, and that specificity was generally most affected by the IgM component. So I don't want to take up too much more time, so I'll just leave this slide up with the acknowledgements. I'll say this was a huge effort by a lot of groups, and it was really initiated by the Marson and Sue labs at UCSF and UC Berkeley, respectively, and also had great input from one of my mentors, Karen Byrne, in the Department of Epidemiology and Biostats. We had a lot of great laboratory volunteers who were very enthusiastic and proactive. So from here, I will just leave this page up or pass it off, I guess. So I just want to thank everyone for their time, and I guess I'll be sticking around for questions at the Q&A session.
Hello, this is Gigi Gromval. I am trying to share my screen. Thank you very much for the invitation to be here. I am, as was said, I'm from Johns Hopkins Center for Health Security. My colleagues and I are a multidisciplinary team that has been analyzing various aspects of COVID. And we have been doing our best to try and provide information to the general public, but also specifically to policymakers. And the document I'm going to talk to you, the work that I'm going to talk to you about today is one of those documents. And it was to try and contextualize and develop a plan for how serology testing could be used in the US, and to try and give the latest information, and also to dispel some misinformation about the value of antibody testing. So as you all know, we endeavored to try and present that serology testing provides very important information, and how this could help, especially in since we had so many troubles with testing early on, and still have persistent troubles with testing, to help to better understand the seroprevalence, and also more about transmission dynamics. So what can serology tell us? I don't want to dwell too much on this, but we want to be able to understand the true prevalence of an infection, to be able to determine the true case fatality rate. We want to better understand the array of symptoms that people have had and yet have experienced the virus. And we have not seen it used, as far as I'm aware, in the US this way, but in other countries, serology has been used to fill in gaps left by contact tracing, looking for viral infection, but trying to fill in the gaps of the epidemiology, and to figure out how one person gave it to another. What we don't know, and we don't know yet, is that if you test positive for having experienced COVID-19, whether that you can say that a person is immune to reinfection. We do not know yet what even if there are neutralizing antibodies detected, and in a paper, a preprint was just posted by Florian Kramer's group at Sinai, that all the people they tested did, whether they were asymptomatic or not, did have an antibody response. We don't yet know, which is positive. It's not positive. How should I say it? It's a good thing, but we don't yet know what levels or how durable those antibodies are, and what how they necessarily correlate to immunity to SARS-CoV-2. We don't know how long this will last, and we don't know. While it's very useful to have serology test results, the biggest case that we were making in our document was that they are most useful for seroprevalence studies, to be able for public health officials to have a sense of who has had the infection, and maybe less useful at this time, given what we know about antibodies for individual decision making. But once we have that, can fill in those gaps, hopefully that it will become more useful for individuals. So what makes a good serology test? We just heard about a great study to be able to compare and examine the limitations of various tests. This has been an issue for the last several weeks, that there were just so many tests out there, and there were tests that were advertised as having high sensitivity and specificity, that actually did not have that high sensitivity and specificity. And also they were being used, even, I'll get into this in a second, but tests that for the general public might think that it was pretty accurate, but would leave you with a lot of false positives. So it was described by many people as a Wild West. The FDA has finally stepped in earlier this week to try and reduce the variation here, and instituted thresholds for antibody tests that these companies have to meet. Otherwise, they have to take themselves out of the market. These companies were allowed to advertise and say that they could, that their work would only be used for research, but it was clearly being used for other things as well. Let's see. We need to see a lot more of the kinds of studies you just heard about, independent, unbiased validation. There is a study that's being coordinated by the NCI and overseen by the FDA that is hopefully will do a lot of that. But we don't know when the timeline is for them to release results or how they're going to be releasing results on their validation studies. Sensitivity and specificity can have a big impact on what you learn from the test. This is less of an issue for public health and doing seroprevalence studies, because if you're testing a lot of people and you know what the false positive rate is, then you can build that into your analysis. But that's the difference of when you have a big N and when you are trying to get information about an individual. These rates of false positives and false negatives could, if you're using it for individual decision making, can be pretty significant. And so, so this is why having tests that have high sensitivities and specificities will be important. And there are some of those tests, at least that they're company, they're claimed by companies to have high sensitivity and high specificity, and we'll see how that bears out. So we've already heard about the different serology test types. Just, you know, there's in our strategy, we talk about how these are all have different kinds of uses and could be useful in different circumstances. 10 to 30 minutes, you can imagine being a lot useful in certain circumstances versus you know, an ELISA or a more intense neutralization assay. Just to let you know about what we're doing, I encourage you to, if you need a resource or an explanation for some text to describe what serology tests do and their pluses and minuses, and why it's important to not use them to have like an immunity passport at this time, or why, if you need to make the case that it is one piece of information that should be used for how you go back to work, and that, you know, other public health tools, including setting up, keeping people from interacting as much, you know, more physical distancing, being able to track cases by active contact tracing. All of these things are important to work together, and that antibodies are not the only thing that you should be looking for. If you need more text for that, I've got the report has a lot of information. It's intended to be written on a more general level. We also are tracking the tests that have EUA, emergency use authorization from the FDA. We have that on our website, so you can check out what new things are coming onto the market, as we'll be updating that twice a week for the foreseeable future. In a couple of days, maybe even today, we are going to be doing a similar thing for molecular tests and all the EUAs that are there for those kinds of tests, to test for active virus. And so, keep a lookout for those. In the plan that we released, we talk about different things that we'd like to see at the national and state level. Most important is to do seroprevalence studies and to validate these tests. And we have a number of research questions as well. Just, you know, basically, what does it mean? I mean, if you get a positive test, what does that really mean for going forward in individual decision making? And that is it. Thank you very much for your attention, and I look forward to your questions. And I will stop sharing. There you go.
This is Dave Rempel, and I'll try to take over the slides again in a second. Liz, oh, here we go. So we've got a lot of questions from the audience, and we'll try to cover them. But first of all, I'd like Ellie Teal to introduce herself and to weigh in on some of the comments.
Sure.
And weigh in on the comments, especially relative to return to work kind of issues, which we'll be discussing in more detail with other questions that have come up. Go ahead, Ellie.
Sure. Thank you, David. Happy to be a part of this today. So I'm a clinical microbiologist. I direct the infectious diseases serology laboratory at Mayo Clinic. And so we have looked at a number of serologic assays, mostly the higher throughput ELISAs and chemiluminescent assays. As Jeff had mentioned, we haven't really looked at lateral flow assays. So I think, just my thoughts are that antibody testing definitely has a very important role to play. I think we're still learning about what that role is. One thing that Dr. Gronvall talked about is the issue of if you have antibodies, does that mean you are protected from reinfection? I think we all obviously hope that we are, but we don't have the data to confirm that quite yet. I think the way I look at it is if an individual is seropositive for IgG antibodies to SARS-CoV-2, they are likely at lower risk for reinfection compared to somebody that is seronegative. But again, we just don't know yet what the level of protective immunity is and how long that lasts. And I think it's just going to take some time to really get those questions answered. And maybe I'll stop there and we can do specific questions.
That sounds good. Thank you. Let me start with some questions for Jeff. They have to really go back to your presentation. You mentioned that there are other groups around the world doing similar kinds of quality evaluations as you're doing. Maybe, I think you mentioned maybe Copenhagen in the UK. Can you talk about what they're doing and also what the NCI is doing? I think they're doing something similar to what you're doing.
So I'll speak a little bit on it. I'll just say it's really great to just read those reports and know that they're out there. I don't know if they can be made available, sort of the preprints can be sent out afterwards. But everyone is sort of generating the same characteristics. It's kind of what's involved for a package insert, which is, or for an FDA submission, which is that you want to know what the clinical sensitivity and specificity of the test is in a certain population. And so everyone is sort of bringing their pieces, their specimen sets and what their evaluation is to the table. And I think that the more of this is done and the more wide scale it's done, the clearer the picture will get. So I don't think there's one clear answer. So really synthesizing all this information together is important. The NCI study that has been mentioned is ongoing. I can't speak too many details on it, that they will be collecting data and doing a more, doing test performance evaluation I believe under the guidance of FDA or in collaboration with FDA. So that looks like that'll be a very centralized place going forward to look for this information. I'm also aware of other sites that are performing test performance evaluations and aggregating data, which would be FIND. The FIND website is also putting out information on the test kits that are being made and also some preliminary reports of test performance evaluations.
Good. Based on your study, when you compare your results to these other papers, are your findings pretty consistent with their findings, or are there differences based on your positive and negative controls and the way you do the studies?
So that's a little hard to comment on. And I guess it's the pathologist in me that says, well, it depends. And I'd say overall, when you look at it, you have to look at these in the context of 95% confidence intervals for the power of these studies. And a lot of these are overlapping. I would like to think that ours are comparable to what other studies are seeing, but I really think that to make a, put a definitive foot down, larger studies will have to come larger studies will have to come out. And then also independent clinical validations within individual populations. So the way this is done sort of in clinical laboratories in the US is that you will, and I should say worldwide, is that you validate a test. You look for a test based on its characteristics or one that you may want to bring it in, and you have to validate it to additional standards for your own clinical laboratory. So those individual assessments will be important going forward as well. So I guess to say that, as I reiterate, the pathologist in me says it depends, and that overall, I think the power of these studies, it's good for what we have, the specimens that are available, but much larger power studies will be necessary to have really good confidence in how these tests perform, how all these tests are performing.
Based on your analysis of the studies, of the tests that you looked at, which tests do you recommend might be considered, and which ones do you recommend not using?
So on that one, I am not going to make a specific recommendation. I'll say that we have published our report, but there's a lot of things that are, we published our report, but it's really up to individual people who are using the test to validate them for their own needs and really look at how they may want to use these for their own needs. Like as evidence comes out about how serology is tested, while there may be no clinical practice guidelines or diagnostic screening guidelines, et cetera, will IgG be more important to people than IgM? Will they have to be used in tandem? Additionally, one other thing that should be thought about is characteristics of the tests we didn't look at that are usually looked at in clinical validations, which is how do these tests perform in the same samples over time? So precision, how precise are these tests? What are their limits of detection if we're able to get quantitative values? So I do not want to recommend, say, any test is particularly good or bad. We present the evidence as objectively as possible. And it will really be up to the application and additional test performance characteristics like precision, limits of detection, et cetera, that are necessary for that testing population.
Thanks. Gigi, I'm going to turn to you and talk about the kind of study that Jeff presented and that the NCI will be studying, and is also done in other countries, these kind of quality studies. Do you know of any place where there'll be a central clearinghouse for the quality of these studies that someone can go to? I know that your site is going to list whether studies are have an FDA EUA or not, but that's not really the same as presenting all the quality data from the studies. Do you know if anyone will be building a clearinghouse for that?
I don't know that. That's if that now that you say it, it sounds like a useful thing that we should think about doing. I do want to say though that the NCI study apparently, at least to my knowledge, is being overseen by FDA or with involvement of FDA. Just to answer a question that came up earlier. But to my knowledge, no one else is planning to be a clearinghouse for that. But I can see how that, now that we'll start getting more of these validation studies, that could be very useful.
Yeah, Ellie, do you have any comments on that?
Yeah, I agree. I think that would be a useful endeavor. Most of these studies will be published in various journals, so having a repository would be helpful and quick. But I do want to reiterate what Dr. Whitman said is, these studies will be helpful, but the clinical laboratories that are running these tests really need to do their due diligence and validate and verify the tests on site, because at times differences can be found between what has been published and what is seen in the performing laboratory.
Thanks. This is another one actually for you, Ellie, I think. In the 2003 SARS epidemic, I believe the WHO recommended a two-phase testing process with a sensitive test initially, and then a more specific and expensive test secondarily. Do you think that that's on the agenda for COVID-19?
Yeah, that is a great question. So for serologic testing for infectious diseases, frequently we have two-tiered testing approaches. Think Lyme, Chagas, HIV. You start with a very sensitive test, and then you proceed typically to a more specific test. Also, the FDA and others have talked about the potential of using two serologic tests for COVID-19. And those two would be based on different viral antigen targets. The concern has always been that in a low prevalence setting, you have a higher risk of false positive results. So if you have two positive results, your specificity would be higher. So that is definitely something that has been discussed. It's not officially recommended yet, to my knowledge, but if I can see why we would want to go there. There's a couple of potential concerns with that. Depending on which assays are used, higher specificity at times comes at a cost of lower sensitivity. So we just have to be able to understand the limitations of that approach and, ideally strike a good balance. And then just thinking from a laboratory perspective, laboratories that are running tens of thousands of these tests, it will delay the turnaround time to these results, which, it's a serology, it's not a critical result, but it's something else to keep in mind. So yes, it's been discussed. I think it's going to continue to be discussed, but we really don't have any data to support that quite yet.
Thanks. I guess a related question is, do you think that it's possible at some point that we might have a low-cost neutralizing antibody assay like a PRNT test that could really provide some stronger evidence of immunity than just IgM or IgG?
Yeah, so a couple of comments on neutralizing antibody testing. These are not easy to perform tests. So the classic plaque reduction neutralization test requires live virus to perform. So one of the reasons that we don't have plaque or neutralization tests routinely available for COVID-19 is that this is considered a biosafety level 3 laboratory that needs higher safety level facilities that most clinical labs do not have access to. So one thing that's being worked on at many laboratory or multiple laboratories across the country is developing biosafety level 2 type neutralization assay tests that use pseudotyped vesicular stomatitis virus that's expressing just the SARS-CoV-2 spike protein. So those assays, I'd say, are under development. I am not aware of any lab offering that quite yet. But hopefully June and July, those will be more potentially available. I think neutralizing antibody tests will be important. Neutralizing antibodies, they're different. So the antibodies that serologic tests detect, they're not all neutralizing. So neutralizing antibodies basically bind to the virus and inhibit its entry into the cell. Independent essentially of any other components of the immune system. So that's why they're important. Right now, one of the challenges is that even if we detect these neutralizing antibodies, we don't know quite yet what level is significant. So what level is associated with, long-term protective immunity? Is a titer of 1 to 10 significant? Is it 1 to 200? What is it, and how long do those last? So there's a few more questions to answer before we know quite exactly how to use these titers. One area that they are useful in right now is for screening of convalescent plasma donors, as the FDA has said that donors need to have a titer of at least 1 to 160. So again, this is another big area that I think we're going to learn a lot about in the next few months.
Thank you. Gigi, do you have any comments on neutralizing antibody relative to a strategy, national strategy?
No, I was trying to look for, there was a really cool preprint from just a few days ago with a with, I believe it was it came out of a Korean university looking at a way to measure neutralizing antibodies without actually doing the test that was just described. So I think I would expect some clever methodologies to come up. And I've been impressed with the variety of things that people have been doing as you know, if you heard about the CRISPR, looking at the molecular side of the CRISPR test that just was talked about. So I guess it's a little bit of a watch this space thing, because we might be able to do better with measuring neutralizing antibodies in the future.
Thanks. There was a question about, I don't know if it's true or not, but a White House strategy document recommending repeat serology tests, 2 tests, to improve predictive value. Gigi, do you know what the time frame for that kind of test recommendation might be for 2 tests?
I do not know what their time frame is, but you know, knowing what the seroprevalence is a valuable thing that correlates with what we have also recommended. So yeah, the strategy document that from the White House is at a super high level and short on those kinds of details. So hopefully we'll learn more soon.
Great. Jeff, I have a question here for you. Can the serology tests that you evaluated, is it possible that they're cross-reacting with antibodies developed in response to the common cold? Or is that kind of a ridiculous proposition?
I wouldn't say it's a ridiculous proposition in that it should be evaluated. And whenever a test is submitted to the FDA or traditionally 510(k) clearance or even EUA, there has to be a cross-reactivity panel. As I mentioned, our study was very limited in that we didn't have access to a lot of these specimens, but the people who are submitting EUAs are required to do that. So far, I just say that it has to be evaluated more, but we didn't see any cross-reactivity between them. But it's not a ridiculous question. It's definitely something that should be assessed by every test.
Great. This has sort of been touched on by everyone, but I'd like you to talk about it in a little more detail. Maybe I'll switch this to Ellie. If someone has IgG to COVID-19, to what extent do you think the person is immune from reinfection?
I think that's the million-dollar question. As we talked about, we just don't have a definitive answer on that. I think we will in the future, but those studies are ongoing. I mean, remember, you know, we did not know about this virus 4 or 5 months ago. We need more time basically to see whether an individual that was infected in February and has developed antibodies, whether or not those individuals get reinfected. That's just something that, you know, at this point, time will tell. As I mentioned earlier, in my opinion, I think it's safe to assume that these individuals are likely at lower risk for reinfection compared to somebody that does not have antibodies. But what level of risk that is, you know, I can't say.
There's a related question for you. Knowing what we know now about the trends in mutation of COVID-19, are the mutations large enough that they might present a risk for a second COVID-19 infection, something like an influenza shift, or are they pretty small?
That's a good question. So I know, you know, right now there's 2 strains that are circulating. One appears to be associated with more severe disease than the other. To be honest, I have not had the time to look at what level of mutations there are between the strains. So I don't know if Dr. Gronval or Whitman have looked into that further.
Are you talking about the recent descriptions of whether or not the mutations indicate that there's that the virus is adapting to that there's a particular mutation that's kind of taking off. That there's a lot of good resources to learn more about that. Now there's a great article by Ed Young in the Atlantic describing this. But just I would say that there's a few papers that show some conflicting interpretations of what you could say. Yes, there is a section of the spike protein that is that there's the genetics there are changing, but whether or not there is also a lot of mutations that are occurring throughout the genome. So it's a matter of is that a specific mutation that is showing, that is demonstrated, that has more fitness and is going to be we're going to see more of, or is it a founding effect of just the way that transmission is occurring? One paper is very strongly leans towards it's just an artifact of who is getting the infection from other people, like just epidemiology versus fitness of the particular mutation. So the bottom line is more reassuring at this point, but a better explanation of this can be found at least in the Atlantic and probably a few other publications by now too.
Thank you. There's a question here for Jeff. Based on the viral proteins S, M, E, and N, are the tests that you're evaluating or that people are developing, are they all directed toward the same moieties or to different moieties, and do they then have different test qualities?
That's a really good question. So we have a list in our supplemental of if the manufacturer reported what antigens they are listing, and there seem to be a fair amount that, I mean, the ones that are being used are currently the spike protein and specifically the receptor binding domain or RBD and the nucleocapsid protein. Some contain both, some contain either or, and some aren't reported. What's really hard to say, is there a difference between both of them, is that what's wrapped into that variable of test performance is just pre-analytical variables of the sort of sample handling and how people are conducting the studies, how the tests are being read, and just the test reagents themselves. So to answer that question, you'd really need something that was manufactured in the same capacity between those two tests to compare that. But I will say that of the tests we evaluated, there was some that contained both, spike, RBD, or nucleocapsid protein.
Right. I'd like to move on to some of the return to work questions that have come up. And maybe we'll start, Ellie, with you. If someone has a persistent positive PCR in their throat swab, is there a value for those patients or workers then in doing a serology test to demonstrate that persistent positive PCR is they're not infectious?
Yeah, great question. I don't think we can necessarily relate a serology result with whether or not the nucleic acid that is detected in their swab is infectious or not. We know that depending on when an individual is infected and tested, they could be seropositive and still shedding potentially live virus, again, depending on when they were tested. There was a nice study in Nature, which I think you alluded to earlier, that showed, I think amongst 9 individuals, even though their PCR was positive for up to, I believe, 2 weeks, the actual live virus stopped, was not culturable any longer at day 8 or 9, and they were seropositive during that time frame. So I think I would just caution against relating IgG seropositivity with non-infectious virus if it's detected by PCR.
Mm-hmm. So again, on the return to work issues, let's take a setting where the prevalence is very high. Let's, for example, let's say that's a prison guards or meat packing plant where the prevalence is 40%. Is there a value in those kind of settings for evaluating workers in terms of return to work and in assigning them to specific kinds of tasks? That's to Ellie.
Oh, yeah, I think it would be, from a research perspective, it'd be interesting to monitor over time how, people seroconvert. Again, because we don't know whether these antibodies are protective or not, it's hard to make distinct decisions on, where we should be placing them, at least in my opinion. I think as we learn more, these antibody tests and their use and utility for return to work practices will be much more important.
Gigi, do you have any response to that same kind of question?
Yeah, the indications look good because reinfections are not something we're seeing. Immunity appears to be lasting at least a certain period of time. But as Ellie said, how long is this going to continue, and what can we, does it apply to everyone? Do asymptomatic people have the same presumed immunity as people who had the disease, had symptoms of the disease? These are all questions that we need to know. I would just caution, as far as, I think that with a good test that has, an understanding of the false positive, false negative rate, I think you can make some judgments, and we do recommend that, that these tests be used when you have a good, accurate, and validated one for essential workers and people who are in more particular vulnerable populations. I think I would just try to avoid creating a situation where you're going to create perverse incentives for your workers that are coming back. I don't think it should be the only consideration for coming back to work or what you're going to do, because you don't want people to try and save their livelihoods to actually try to get the disease. For them, it might be a bad situation to do that, but it also may be bad for all of their contacts. And just to try and avoid this, creating such an environment where people feel like they need to do that.
Thank you. That's a good point. So if you were managing a nursing home and providing medical management for employees working in a setting like that, at this point, you would not use serology testing to help place workers in the nursing home settings based on how close they are to the elderly?
See, I think that it's got some value there. I just would be cautious of how much, because we just don't know all of we can presume some immunity, but can we presume that they're not having some low level of infection and are still that they're able to transmit or not? There are too many unknowns, but it might help for PPE decisions. It's a very hard thing, but I feel confident that we're going to have more data to be able to help people with these decisions.
Mm-hmm. Good. One of the other specific kind of processes would be workers going to a site where they're isolated with other workers, for example, going to an offshore well, where they have to work in close proximity with other workers for 2 weeks. Do you think a process of doing a PCR test, a swab combined with the serology, has value in deciding who should go to the well or who shouldn't, or how they should be managed once they're at the well? It's a place for a high risk, and employees are worried about getting an infection from someone else. And then, of course, healthcare is not available.
So this is Ellie. I think in those situations, we definitely want to, as you said, do molecular testing, confirm that they are not shedding active, not shedding virus. I think that's really the most important test to perform. The serology testing with that, I think, is more just additional information, but it's probably not what we're going to base the decision off of on whether or not that individual should go to an isolated location for work.
So related question, if you were to do the serology testing on all employees working on the offshore site, and some of them had a positive IgG, would you bother doing a PCR?
Yeah, so good question. Typically, if they're IgG positive, entirely asymptomatic, hadn't had symptoms, recently, that would suggest that they were, infected at some time in the more remote, if you will, past. But if they're IgG positive and they had symptoms, to 8, 10, 11 days ago, then I would want to confirm that they're not shedding virus with a PCR. So I think timing of when the testing is done is really important.
Mm-hmm.
I think given the fact that there's people can be asymptomatic and and that there's overlap and when you can test positive for serology and also be shedding virus, I think it seems like it would be valuable just to do the test.
I agree. Given the high rate of asymptomatic infection, I would agree with that. I mean, in general, we'd want to do PCR testing, like I said, to make our decisions on a yay or nay to go to remote or other locations.
Uh-huh. So I'm basically hearing at least currently, relatively little value from a practitioner standpoint, from a practical standpoint about return to work or worker placement for serology. Is that a reasonable interpretation I'm taking from your talk, Gigi?
Yeah, I mean, I don't want to overstate it. I mean, because it looks, since indications and looking at the people who have recovered, they don't seem to be getting reinfected. We would certainly see that in the literature now. I mean, there must be some value in having proof that you had been infected in the past. But the challenge of how you use it, whether or not it's you should remove that person from needing to use PPE or anything else. There are enough questions that I think it's more useful information, but it cannot be the only piece of information and tool that you use to be able to place people or to how you specify people's behavior once they're in the workplace.
Ellie, do you agree with that?
Yeah, I really do. As Gigi said, it's really, and I think at this point, an additional tool to help us assess risk and understand, patient's immune response. But we really, in my opinion, we just need to know a bit more about what a positive result means, and how long do those antibodies last? Are they protective for 6 months, a year, what have you? I think it's additional information, and we'll really be learning a lot more about how to use these tests in the future.
Jeff, do you have any comments on that kind of conclusion?
No, I agree with all. It's really the application and the biology, sort of all those things meeting together, as I showed in that Venn diagram, is where these answers and insights are going to come from. And the pieces are just starting to fall into place.
Mm-hmm. Good. We're going to wrap it up in a second, but Jeff, there's questions about how to get the results from the NCI/FDA/CDC evaluation of serology test quality. Do you know how when they're going to publish that and in what format will be available to us?
No, I do not. There was a call yesterday on a serology workshop put out by NIH, and it was discussed what they were going to be doing, but I didn't hear any timelines. But I also don't want to speak out of turn, but I'm not aware of any.
You said that they've already done some tests on a handful of serology studies. Are those available?
I don't know if those are available or not. And sort of per the reports that I've heard, just at least what's been covered is that those will be reported at a later time. So I have no timeline for that, unfortunately.
Ellie, do you have any insights?
Not specifically. I think the FDA has a website where they've published the performance characteristics for the EUA, the assays that have received EUA. And it looks to me, a couple of them looked like they had been evaluated by the NCI project, but it wasn't specifically mentioned. So I think they're really actually still working on how best to disseminate that information.
We will, for our tracker, we kind of sift through some of the package insert details and give you, top line specificity, sensitivity on the ones that have EUA approval, and we'll keep track of that. But to my knowledge, the fact that they were doing this was announced, I believe, on April 12th, and no results have been offered yet.
Well, Gigi, one of the recommendations I think you heard may be that that your site might want to be one of the ones that provides a clearinghouse for some of the publications on the quality test of serology. And I hope you take that under consideration.
Thank you. Yes, I will.
Great. So we're nearing the end of this of the webinar, and I wanted to give each of you, a minute or two to summarize the main take-home messages, especially relative to the people listening who are trying to decide about return to work and work decisions. And it seems like we're still at a pretty early stage in the application of serology, so it seems mostly we're a cautionary notes. But Jeff, let's start with you.
Okay, so I guess the takeaway points for me are that as a laboratorian and clinical pathologist, I think understanding the methodology and the molecular biology behind both the disease and the test and the testing modality is really important. It doesn't have to be, I guess, you don't have to dive in too deep, but it should be great to have a cursory knowledge of the tests that are being ordered and that may be happening behind closed doors in the clinical laboratory. And in general, clinical laboratorians are more than happy to discuss the tests that they have validated and what they've done and what they are using. I also think what format the test is in is really important, whether people want to have something that is run in a laboratory or more of a point of care style test. But then the decisions to use a point of care style test also have regulatory aspects wrapped into it about whether you can do it in a physician's office or not, which could require a CLIA waiver, which is additional regulation. There's a lot of stuff around that. So I'll say that testing, the testing format I think is important, and it's really good for individuals who may be ordering these tests or interpreting them to know how they function. And then it's also great to understand when you're looking at these clinical sensitivity and specificity data, whether it's from the manufacturers, from the FDA, or from independent studies, to know how those studies were designed, to understand their strengths and weaknesses when you go into making a decision on maybe a test you may want to order for your healthcare system or where you may be using it.
Just before we leave that point, one of the issues in terms of quality evaluation is the characteristics of the positive and negative controls. I know you've thought about that, what should be a positive and negative control in your study. Can you think of studies in the past, especially maybe ones done elsewhere, where they used poor positive and negative controls and what that would be?
So I can't think of one that would be poor positive or negative controls. But one thing I'd like to point out here is that we don't have actually any gold standard for serology. So when you want to compare test to test, you actually want to compare. The best thing to do would be something that you know is absolutely IgG positive and you have some sort of quantitation on that. And you're comparing, in that situation, an apples to apples. So you're comparing one serology to another. What we have now is a little bit imperfect in that we're still working out the serology. So a lot of it is being compared to the context of a nucleic acid amplification test or the PCR test. And so the assumptions you make have to be kind of in light that these are measuring two different aspects of the infection, one that is directly related to the pathogen and then one that is related to the host response. So all these test performance characteristics that are being generated have to be made in light of that. So sort of answers the question, but maybe not completely.
Yeah, thank you. Gigi, what conclusions do you draw for the audience?
Just that these tests are going to be in high demand, but just to be cautious about the uncertainty. They shouldn't be used as a single tool. They should be considered within a context of other public health tools and measures that are used to limit spread. Contact tracing is where it's at, and be aware of creating perverse incentives.
Thank you. Ellie, any conclusions from you on this?
Yeah, I would say that, so speaking from like the clinical laboratory, I feel that in this situation, we kind of put the cart before the horse when it comes to serology. We had a test, many tests available before we fully understood how best to use them. And typically in lab medicine, testing is done for the purposes of making a decision of some sort. And right now, as Gigi mentioned, the decisions that we can make based on a positive serology result are, I think, kind of limited. I think serology is really giving us additional information at this point. And as we get more information, more data on the the level of immunity, I think knowing what those serology results will be more important moving forward.
Before we leave, I'm going to put you on the spot one more time, and that is Jeff. I couldn't put Jeff on the spot around which test to select, but I'm going to put you on the spot. If you look at Jeff's study of different tests, how would you use that to guide you in the selection of either lateral flow assays or ELISA assays for your own laboratory use?
Yeah, so we're also a reference laboratory. We do thousands of tests a day. So doing a manual test like a lateral flow, whichever it is not something that is feasible from a workflow or FDE perspective. So my laboratory is really more interested in these automated assays, be it ELISAs or chemiluminescent based assays on automated instruments. So it really depends on your laboratory environment and throughput that is needed. But his data is important from a quality perspective. But again, each laboratory needs to do their own internal validation before offering any test.
Thank you. So we're going to stop at that point. We reached the end of our hour and a half. And I want to thank the three speakers for joining us and presenting at this serology session. And at this time, I'm going to turn it over to Elizabeth to wrap it up and provide any last announcements.
Thank you, Dr. Rumpel. Another fantastic presentation today. So again, we really appreciate it. And on behalf of the ACOM leadership, thank you and the panelists for presenting today. Today's webinar was recorded, and a link to the recording will be emailed to all registrants. And the link will also be posted online at acom.org. Please join us next week for a free webinar on preparing for large-scale return to work, a strategic and proactive approach, which is on May 13th. Registration is available at acom.org. And to all of our participants, thank you very much for joining us today. Be safe and have a great day.